Welcome to Unloading, a community podcast focused on illuminating the diverse perspectives across the country about solutions to the epidemic of gun violence. I'm Kate, a fourth-year medical student from the University of Colorado.
I'm Mijo, also fourth-year medical student from the University of Colorado.
I'm Sarah, a third-year medical student from St. George's University.
Our hope is that these stories will inspire you to learn more about gun violence and take action in your own community. Hello, everyone. Today we have Dr. Megan Evans, who is an obstetrician and gynecologist at Tufts Medical Center in Boston, as well as an associate professor at the School of Medicine. She has a master in public health from Boston University School of Public Health. Dr. Evans has a strong interest in advocacy and health policy, serving as national president of the Medical Student for Choice and board member of Physicians for Reproductive Health Board of Directors. She also holds several leadership positions, one of which is in the American College of Obstetricians and Gynecologists. She's currently the secretary and treasurer of the ACOG Massachusetts section. She served as the ACOG Junior Fellow Congress Advisory Council Chair from 2015 to 2016, representing over 10,000 ACOG Junior Fellow members. She writes an advocacy column for OBG Management and is co-founder of the O+G podcast, focusing on topics related to health and policy and advocacy. So thank you for being here today, Dr. Evans.
Yeah, thank you for having me.
Start off our conversation for the night. We read the NEJM perspective piece you co-authored in 2020 about IPV during the COVID-19 pandemic, and you recommended normalizing screening for IPV by using standardized questions and offering information to all patients, regardless of whether they disclose IPV. Do you approach conversations about gun violence similarly in your practice?
Yeah, I think it's important to ask everyone the same screening questions because I think that's where we can get into trouble in medicine, where we insert our own biases into what we think we need to screen the patient for. And I have seen this before where some patients are screened for opioid abuse and others are not, simply by their demographics. And so I think this is true of intimate partner violence, making sure that we screen everyone because you never know what patient is being impacted by intimate partner violence. And as an OBGYN, I screen every patient every year when they come in to see me, but I also ask, is there anything about being at the gynecologist that's hard for you? Because I think that there's some people that may not register some of the trauma they've had, whether that's medical trauma or trauma through intimate partner violence, in the same way when they're coming into the physicians. Gun violence is the same. We don't know who is impacted by gun violence, and we certainly don't want to insert our own biases. And so, kind of when you're going through those social determinants of health, is there a gun in the house? Do you have practices to safely store that weapon, that gun?
I really like that you're approaching gun violence screening as such a standardized practice. I think that is something that could really help out a lot of patients who may not voice their concerns. Do you feel like the current IPV screening tools like HITS are specific and sensitive enough? Because I know that you mentioned a little bit about your own questions that you asked. Do you think that we need additional screening methods to better assess these patients?
I think in a perfect world, when we had 30 minutes, 45 minutes, an hour to sit with every patient, I think that there are probably ways that we can ask these questions better, or maybe uncover some, concerns that we have with our patients' home life, with their partners. I think the screening tools that we have are good. They've been validated. I think the more important part is that people use them and they use them consistently. When patients come in, the hard part is you have a lot to cover for many patients, and sometimes you have 15 minutes or less to review all of that. So I think screening for social determinants of health, screening for intimate partner violence, it can be effective and efficient. And I think that these simple questions, the one that I use is typically 3 questions. I think that is sufficient just to kind of open the door to that conversation for patients.
In situations where you're worried about whether it's safe for a patient to return home due to guns, maybe they had some red flag comments during your interview, but it doesn't seem like something is going to happen acutely. How do you navigate that situation and open those kinds of discussions?
Those conversations are hard. And I will say that I think that there's, I understand this. I think there's probably quite a few physicians in practice who maybe don't ask the questions because they don't know what to do if the answer is positive. And we're fortunate in our own practice in that we have a social worker who's on staff. So if a patient screens positive for intimate partner violence, or we're really concerned about their safety at home, we have the ability to engage with our social worker right away. And I think it's important to know that not every patient is ready, one, to disclose, is not ready to make a plan to leave their partner. We know that when a patient tries to leave an abusive relationship, it's actually one of the highest rates of when patients might be harmed or killed. And so oftentimes these discussions about safety and violence at home it's not a one-time conversation. It's a conversation where you're developing trust, a relationship with that patient. You talk about what resources are available, where there are shelters, how to make a safety plan. And at times, the patient might be ready to discuss that, and they may not be, and they may never be ready. And I think that, that can be really challenging because we want to get patients into a safe place with their partners and with their home lives and with their families. But so much of it can be a stepwise process, and just providing the resources in a safe place is really important for the patient.
Absolutely. I think we have to meet patients where they're currently at because the provider-patient relationship is extremely important to maintain. For medical students, what reporting systems are available if we have patients who do wish to report concerns about violence from a partner and firearm acquisition?
Yes, if a patient wants to escalate their concerns with an intimate partner who they're in a violent relationship with, or they're violent around family, or they're concerned that they might actually harm themselves, then we do, fortunately in Massachusetts, have a red flag law. And so you can actually report some concerns if this person has a firearm. And because of our red flag laws, if they might be a harm to themselves or people around them, then you could advocate for their firearm to be removed. And it actually is really hard for that person to get their weapon back. We know that red flag laws save lives. So when states have a system of removing firearms from someone who is a perpetrator of intimate partner violence or is at risk of suicide, we can reduce homicides in some cases up to 25%.
Wow, that's a huge number.
Mm-hmm.
When you are reporting, when there are red flag laws in place, who do you contact to start the process? Is it care management or the department chair, or do you directly call the police yourself?
So there's certain requirements of who can submit a red flag request, and that is someone who is married to the person, who lives in the same household, is related by blood, has a child with that person, or has been in a serious relationship. So, not necessarily married, but has been with that person for some time. And there's a way to report that on our Massachusetts website, mass.gov, for them to report that to law enforcement. So it actually would not be me as a physician. So what's challenging is we're not mandated reporters for intimate partner violence. We are for child abuse. You cannot report concerns of a domestic violence if the patient doesn't want you to.
What advice do you have for medical students and providers that unfortunately don't have these reporting systems in place? What would you suggest for them the best steps may be?
For a patient who is concerned about their partner having a weapon or a gun?
Yes.
Well, I think there's layers to that I can answer. I think one-on-one for the patient, I think that you want to come up with a safety plan for them and maybe, talk about ways to safely store that gun, that they can engage with their partner, especially if there's a child in the home. I think you probably know this, but just came out the number one cause of children's death is guns, which is the first time in a long time that that's been the case and not accidents. So starting individual conversations with that patient, and especially a safety plan, even talking about how they can de-escalate a situation. And then, within the hospital system, I think that you could provide materials in women's bathrooms. So they could identify ways that they could find resources not only for intimate partner violence, but if they were worried about gun violence at home. And then at a kind of a community level, talking to legislators about trying to pass red flag laws. I promote the red flag law we have in Massachusetts, but some of our neighboring states don't have those. And so people can cross state lines, and there's also loopholes through gun shows. You can get weapons through family. So, our system is certainly not perfect, and other state laws impact what happens to our patients here. And then thinking about a national advocacy efforts to try to get red flag laws, background checks, which is making some strides, eliminating the gun show loopholes for people to access guns too. So it's a lot of different ways to think about how you can help that individual patient.
Amazing. Thank you for sharing that. So another question that we have for you kind of focuses on a different population that is also affected by gun violence. We've read some studies that kind of show that transgender individuals may experience a disproportionate IPV burden compared to cisgender individuals, but there's no specific recommendations for IPV screening for transgender individuals in the U.S. Preventative Services Task Force recommendations. Do you think that we underscreen this patient population?
Absolutely. And I think that comes down to our biases too, and that there's sometimes assumptions about different populations that maybe they don't experience the same amount of intimate partner violence. I'd like to believe that certain task force don't believe that they're not deserving of that screening. I don't think that's the case. I more think it's probably a lack of knowledge and understanding. I think back about how sometimes people think that women in same-sex relationships shouldn't get pap smear screening because they're in same-sex relationships. That's absolutely not true. And if anything, women in homosexual relationships have a higher chance of having abnormal pap smears and potentially cervical cancer because they're underscreened. And so, this is a kind of similar, I think, potential bias that happens where people assume that transgender populations aren't at risk of intimate partner violence at the same way as people who are cisgender, which is absolutely not true.
Absolutely. I think it's really important that we always keep our biases in check and assess how they might be influencing how we interact with our patients. Given that physician advocacy is a passion of yours, what are ways we can effectively advocate for our patients in the realm of gun violence in all levels of training, from medical school into residency and into attendingship?
Yeah, I think a lot about advocacy in different layers, like I said before, because I think that sometimes people think about advocacy as only legislative advocacy, and there's so many different ways to advocate. And for you all, if you have a patient story, keep that patient story, write it down, obviously HIPAA compliant always, but write down that story, because those are the stories when you do talk about things, when you do meet with people, when you do talk to legislators, that make a difference, because the numbers are important and the statistics are important and, certainly sobering, but the patient stories are what stay with people. So that's one thing. I think it's tough as a medical student because you want to navigate your rotations carefully. And certainly if you're thinking about certain fields, you want to navigate, but when you're curious about how do they screen for social determinants of health, how do they screen for intimate partner violence, and do they screen for gun violence? And I think that you'll find different answers on different rotations, I'm sure. Pediatrics probably routinely screens for it, whereas some of the other fields may not. And so it's just more curiosity about how people screen. If you have the opportunity to give a presentation and there, you could talk about gun violence and especially intimate partner violence. I don't think everyone always thinks about this, but when you think about the mass shootings that occur, one common denominator is they're typically perpetrators of intimate partner violence. And so that's always kind of a line that you can draw, and that mass shootings impact a lot of people in different ways. And so that's something to think about. Advocating for background checks and red flag laws in your communities at a nationwide level, that's another way. And whenever we go to the Hill to advocate, or we go to the State House in Massachusetts, I never want to hear a medical student say, well, I'm just a medical student, so I'm not going to say anything. The legislators care far more about what you have to say than what we have to say as attendings, because you're viewed as the future of medicine. What do you care about now? And you have way more knowledge about healthcare, human body, reproduction than the people who write the policies. So always remember that. And then even you could create a resource for faculty, for residents, to think about these things. What screening tools do people have? Does your hospital use Epic? Make a dot phrase where people can just write .IPV screening or .gun violence screening, and then people can pop that into their exam and ask the simple question. So there's a lot of ways that medical students can advocate.
I love the idea about creating smart phrases in Epic. I would definitely have never thought of that. I think it would be incredible to bring that into our various specialties like family medicine, OB-GYN, and pediatrics, just to help make a standardized practice and make sure that all providers are screening for these types of things. And our last question is, when approaching your advocacy work, especially with such a large problem like gun violence, sometimes it can feel daunting as though our individual efforts may not make the biggest difference. What advice would you give for advocates who are facing this kind of discouragement?
Yeah, I mean, I think that's a great question. I think that advocacy is hard. And for me, it fills my cup for sure. It reminds me of why I went into medicine. It reminds me of why I specifically became an OBGYN, because that component of my work is incredibly fulfilling. That being said, it can be daunting and discouraging at times. And certainly when we think about, what's happening right now, I just saw a group in the South who voted to oppose IVF. That's where we are right now with just kind of daily actions that are happening against personal freedom, reproductive freedom. So it can be discouraging. And I would say the best thing to do is take care of yourself, because you cannot be a good advocate if you're not well. And so sometimes you just have to take a break and not look at the news and not feel like you're not doing your part because you're not participating, because sometimes you have to take a step back. I would also say to remind yourself sometimes of why we need to advocate, because the people who this impacts can't always use their voice. And so we're speaking on behalf of them. We're speaking as their, advocates. And I think that that is a good reminder, especially so many people went into medicine because they wanted to help people and care for people. And then I do talk to residents a lot about redefining what a win is, because I think sometimes it's not always all or none. So, with gun violence, we're probably not at any time going to ban assault rifles or ban weapons altogether. And so I think that if that's how you define a win, it's going to be really hard to achieve that. But if you can define a win as getting the background check bill passed in your home state, or if you can get that many more legislators to talk about gun violence, and maybe next legislative cycle, you'll get a win. Those are things that I think can feel incremental, but can make a big difference. You work hard, but sometimes it can be big rewards, and it can take some time to get there.
Absolutely. That reminds me of a book. I think it's called Saying Yes to Change, where they talked about how wins sometimes need to be very small. And that's how you can help keep people motivated.
Mm-hmm.
Because if you make really big, lofty goals, while they're great, sometimes it can be disheartening when it takes so long to achieve them. And focusing on smaller, more short-term goals and wins can really help boost morale.
Yeah, absolutely.
And that was our last question. So thank you so much to Dr. Evans for taking the time to let us interview you.
Yeah, of course. Thank you for having me. It's such an important topic. And I think, it's something that we don't talk about as much as we should. And, it's so important to think about these things when you're caring for patients.
Thank you for listening to Unloading, a community solutions podcast for gun violence. This podcast is in part of the American Women's Association Gun Violence Task Force.